Hello, thank you, Dr. Kim, for the invitation to participate in the 2024 Asia Pacific Cardiovascular Intervention and Surgery meeting and this seminar on congenital heart diseases. My topic today is the history of adult congenital heart disease clinics in the United States, and I'm sorry that I can't be with you in person. I have no disclosures with regard to this presentation. Adult congenital heart disease is a field of cardiology which has emerged and experienced dramatic evolution over the past 50 years, and that's based on success of pediatric cardiology, cardiovascular surgery, and imaging. And some of the highlights, of course, include antenatal diagnosis, echocardiography, and sophisticated cross-sectional imaging, pharmacologic advances, diagnostic and interventional catheterization, cardiothoracic surgery, as well as pre- and post-operative intensive care. No discussion about congenital heart disease is complete without introducing the advent and development of congenital cardiac surgery. And we can see here that before the cardiopulmonary bypass and cross circulation were performed, only basic congenital cardiac disorders could be repaired, such as patent ductus arteriosus, first repaired in 1938, aortic coarctation, first repaired in 1944, and then the Blalock-Taussig shunt the same year to improve the saturation of patients with cyanotic heart disease. And then 1952 saw the advent of atrial septal defect closure using hypothermia, as well as placement of a pulmonary band. But note that after cross circulation and subsequently bypass were available, that the number of operations and the complexity of surgery that could be performed was quite striking. With the first repair of tetralogy of Fallot occurring in 1954, where apparent was the patient's cross circulation. In 1956 and 1959, we saw atrial switch procedures with the Senning and subsequently Mustard operation for transposition. Neonatal cardiac surgery started in the 1970s, the Fontan operation in 1971, and arterial switch procedure in 1975. And finally, the Norwood operation in 1980. And these are just highlights of some of the operations that are available today for patients with different types of congenital heart disorders. This map shows, of course, the continental United States with a heart demonstrating not just where I am today and where I live, Minnesota, but also representing one of the most important areas for the development of early cardiac surgery. And of course, all of the cardiac surgery that was performed early was for congenital heart disease. And it was by these three pioneering surgeons. First operations performed by Dr. C. Walton Lillihei, as demonstrated on the left. And he operated at the University of Minnesota in Minneapolis, just 80 miles from where we are at Mayo Clinic. And the two surgeons on the right, Dr. John Kirkland and Dr. Dwight Magoon, operated at Mayo Clinic. And so these three surgeons started cardiac surgery or intracardiac repairs in a small area in Minnesota, really quite unique. And that important development resulted in pediatric cardiology not just being, especially for complex cases, not just being the care of infants, but also children, and also allowed us to think beyond childhood and into adulthood. And adult congenital heart disease now is recognized as such an important area. In fact, in the United States, 97% of babies born with congenital heart disease are expected to survive to adulthood, and 70% of those alive at age 18 will live to become 70 years of age. We know that more adults are living now with congenital heart disease in the United States than children. The majority of these are individuals with fairly mild congenital cardiac disorders such as ASD, VSD, and PS, A third have more moderate disorders such as coarctation, repair tetralogy, bicuspid aortic valve with aortic stenosis, or Epstein anomaly. And only 10% have complex disease such as single ventricle, pulmonary atresia, or transposition. So again, providing lifelong care became important, not just in infancy and childhood, but also young adults, middle age, and older adults. As we know now from these data that most of our patients who live to 18 will get into their 70s. Also very important to think about unique patient populations. What about the young woman in your office? Is it appropriate for that patient to consider pregnancy? What will the outcome be to her and her infant? And when should we counsel against pregnancy? Which lesions are the highest risk? Those are all things that prompted the development of adult congenital heart disease. So as we look at the early days of adult congenital heart disease, we have to go outside of the United States and start with the UK. Dr. Jane Somerville is considered the mother of adult congenital heart disease care. In 1975, she raised some funds to open the world's first hospital ward that was solely used for children and adolescents with congenital heart disease, and she named that the Paul Wood Ward. So 1975, the first specialized care for adults with congenital heart disease in the UK, 1975. Going ahead a couple years, Dr. Joseph Perloff, considered the father of adult congenital heart disease care, was recruited to UCLA as professor of medicine and pediatrics in 1977, and there he started the first United States adult congenital heart disease clinic. And that still exists and is an incredibly strong center for the care of patients with congenital heart disease. Next, we move to Toronto, and in 1986, Dr. Gary Webb moved to Toronto and established the Toronto Congenital Cardiac Center for Adults at the Toronto General Hospital. It was and remains a major North American center. And then back to the United States, Dr. Carol Warrens. She was trained by Dr. Somerville and in 1987 was recruited to Mayo Clinic to start the Adult Congenital Heart Disease Clinic at Mayo Clinic in Rochester. And building on the rich history, surgical history, there were, of course, many patients that required this expert care. So 1975 to 1987, really dramatic development, the early days of adult congenital cardiac care in the US, but also in the UK and Canada. So started in the United Kingdom, then to Los Angeles, Toronto, and Minnesota, the early days of congenital cardiac care. So again, the parents of congenital cardiac care, Dr. Jane Somerville and Dr. Joseph Perloff, had early disciples in Dr. Warrens and Dr. Webb. And these individuals not only provided fantastic care to patients, but also were incredible educators. And they then took upon themselves to educate individuals, not just at their centers, but globally, about this important area of expertise. And were pivotal in not just developing this specialty, but also emphasizing that it really needed to be a global initiative. And of course, there are too many individuals to mention, but you'll recognize some of these superstars demonstrated here. So let's then turn to a discussion about the current era of adult congenital clinics in the United States. And to do so, I think it's important to talk about the Adult Congenital Heart Association. This association was founded in 1998, and it's an organization that was begun by and dedicated to supporting individuals and families living with congenital heart disease, and also advancing the care and treatment for these patients. I often turn to the website to help me identify a location where a patient of mine can receive specialty care. And note this map depicts the centers that are present in the United States. So 115 U.S. clinics that have specialized adult congenital heart, or indicate themselves that they have specialty adult congenital heart disease care. I think it's also important to note that the propensity or the majority of these centers are what we call east of the Mississippi. If you draw a line through the middle of the United States, the majority of the centers are east of that line. So more difficult for patients who live west of the Mississippi to find specialty care. So these centers are self-proclaimed, but there is actually an accreditation process that is present currently, and there are only 54 U.S. accredited adult congenital heart disease clinics. And you might ask, well, what is an accredited adult congenital heart disease clinic? The association, the Adult Congenital Heart Association, developed an accreditation program, and that was initiated in 2017, and it was designed to improve and standardize care for patients with congenital heart disease, for adult patients with congenital heart disease. And the requirements for this include the following. One, each center that's accredited need at least 2 board-certified ACHD MDs, at least 1 nurse and 1 nurse practitioner, access to cardiac surgery, ICU, and cardiovascular anesthesia, heart failure and transplant services, interventional catheterization, heart rhythm services, and also need an inpatient service, including 24/7 calls. So someone's on call all the time for emergencies affecting patients with adult patients with congenital heart disease. And you might think this is a lot, but look, there's more. These centers that are accredited also need to have outpatient services with ready access to appointments, particularly if urgent, transitional services from pediatric cardiology to adult congenital care, patient-centered care, advanced imaging for congenital heart disease, including echo, cardiac MRI, and cardiac CT, care for patients with pulmonary hypertension, including a pulmonary hypertension specialist who has experience with regard to these patients, exercise testing and cardiac rehab, reproductive services and maternal fetal medicine, and psychology and social work. And these all need to be readily available for patients that are seen at an accredited center. So as we go back to our timeline, from 1975 to 1987, 4 clinics, and as you can see after that, many, many more, over 100, but only about 54 are accredited. So in 50 years, there are 54 accredited adult congenital heart disease programs in 28 of the United States and also in Washington, D.C. So let's look at the next chapter, and that is triumphs from the past and future challenges. So in the past, some of our challenges included diagnostic accuracy. So in the early days of congenital heart disease, the cardiologist would do a physical examination and only occasionally send patients for cardiac catheterization before intervention. Surgical mortality was high, including intra-op and post-op, with problems including stroke, infection, and bradycardia. There was lack of evidence due to limited numbers of studies and uncertainty regarding results because of the lack of long-term follow-up. Now, today's challenges are different. We've really sorted out some of these problems that really caused issues early on in the care of adults with congenital heart disease. But today's challenges continue to be diagnostic accuracy, But now the landscape is different because we're challenged by multiple lesions in the same patient. We also note that surgical mortality is still an issue, but not because of the things that challenged us in the past, but now our patients are older. They have multiple prior interventions and often have multi-organ dysfunction. There is lack of evidence, but it's not about the prior operations that we used to be concerned about, but there are limited numbers of studies in adults and new diseases that occur. And then there are uncertainties about results, particularly lack of long-term follow-up with some of our newer surgical and catheter-based interventions. Congenital heart disease management successes have resulted in new challenges. The increased lifespan means that there's a higher risk of acquired cardiovascular disorder in our aging adult congenital patients. And they include, of course, heart rhythm problems, heart failure, coronary disease, pulmonary hypertension, the need for additional interventions, and in some situations, even cardiovascular oncology. Also, higher risk of disease impacting multiple organs, the liver, the kidney, the endocrine system, neurology, mental health, and of course, infection, always on the lookout for that. And so we were so excited about the Fontan procedure, the cure for cyanosis in patients with single ventricles, until we recognized and followed these patients long enough and identified the problems that this important operation can result in. Problems with the liver, problems with the lungs, the kidneys, the gut, the brain, and so on. It's also, I think, important to recognize that the number of procedures, the Fontan procedure, is fairly stable for patients with double outlet right ventricle, tricuspid atresia, and common ventricle, as depicted in blue, gray, and red on this graph over a 14-year period. But note that that operation for hypoplastic left heart syndrome is increasing. And of course, these are ill patients, particularly when they get to be in the adult congenital heart disease age group. So we really do need multidisciplinary care teams. And the adult congenital care team, an example is depicted here. And of course, cardiology, the nurse and nurse practitioner, imaging, cardiac surgery, anesthesia and ICU, and importantly also genetics. But our patients need more support, as was already impacted and emphasized by those criteria required for accreditation. And we need heart rhythm, advanced diagnostics, pulmonary hypertension, cardiovascular and vascular interventions, maternal fetal medicine. And as the patients get sicker, heart failure, heart transplant, and palliative care also so important. And I think we talk to patients about the potential for transplant in the future, but need to be aware of the possibility that this might not be an option for every patient. Note that the number of congenital heart disease awaiting transplant or listed for transplant continues to increase, but the number of congenital heart disease patients that are actually transplanted, the increase is less striking. So as we conclude, I think it's important to think about future opportunities. And one group emphasized organized tertiary centers, training professionals, collaboration, both national and international, randomized control trials, and then some thoughts about biobanking, e-health, artificial intelligence. And how can artificial intelligence help us? Well, this is what this particular group thought. It can help us solve diagnostic problems, predict outcomes, guide medical decisions, improve precision healthcare, enhance cost effectiveness, and improve the patient's quality of life. So over the past 20 minutes, I think we've reviewed the past experiences, we've highlighted some of our present challenges, and we look forward to future opportunities to advance this important subspecialty in an effort to continue to improve the lives of patients with congenital heart disease. Thank you so much for your attention.
Thank you, Dr. Connolly.
So we'd like to move to the next speaker. Next speaker is Dr. William Miranda. He's also a Mayo Clinic, and he's a program director of the adult congenital heart disease. He will join for the online, right? It's okay? Connect?
I don't know.
Record it?
Morning.
Okay.
Morning. First of all, I want to thank the organizing committee for the invite to be here. To be here. It's truly an honor to be part of your meeting. And I've been asked to speak on invasive cardiac hemodynamics in adults with congenital heart disease. And as I was putting the talk together, this was actually quite challenging because there's a lot we can talk about. We can talk about CCTGA, we could talk about absence anomaly lesions that we commonly see at Mayo Clinic, but we can even talk about simpler lesions like an atrial septal defect. Now, instead of talking about several different things and being superficial about it, actually I want to focus on one issue, and I want to talk about invasive Fontan hemodynamics. And the reason for that is because the group of Fontan patients is rising, and you will be exposed to it whether you like it or not. Now, I have no disclosures for the talk, and here's the outline. We're going to review normal Fontan physiology, we're going to discuss exercise Fontan hemodynamics, and finally, at the end, we're going to talk about some alternatives, some other tools that we can use even before the patient comes to the cath lab. So in other words, tools you can use in your clinical practice when you see these patients in your office. Now I want to start with a case. So this is a 26-year-old patient of mine that was admitted to the hospital with unequivocal Fontan failure. And he had no ventricular dysfunction for quite some time, but he was completely asymptomatic prior to being put in the hospital. And as we commonly see, his treadmill performance was quite abnormal with a peak VO2 of only 49% predicted. His physical exam did not show a CVP that could be appreciated, but his abdomen was quite distended due to large volume ascites. And his labs were quite abnormal, so he had markedly elevated liver function tests, and his BNP was north of 30,000. Here you can see his echo. On the left-hand side, you can see he had a dominant RV, which was quite dysfunctional, and he had quite a bit of AV valve regurgitation. We diarised him for a couple of days, and as we typically do, we brought him to the cath lab to understand things better. And here you can see his set of numbers. So PA pressure of 12, wedge of 8, cardiac index of 2.1, and an arterial saturation of 88%. And I think before we even try to interpret these values, I would like to go back to the basics. And I want to start with what Fontan physiology is. Now, the Fontan procedure was designed for patients with single ventricle physiology. And the idea here is to actually divert the systemic venous return straight into the pulmonary arteries, leaving the ventricular chamber for the systemic circulation. And as we do so, we invariably result in systemic venous hypertension. That's one of the hallmarks of the Fontan procedure. In contrast, we actually result in P pressure hypotension. This was one of the pet peeves of Professor Mark Delaval. And as we think about these abnormalities and we add the non-pulsatile nature of venous return, it's unsurprising that we would be concerned about ventricular underfilling post-palliation. That has led to this idea that Fontan physiology is a low flow state. But the question is this true in 2024? And as we go back to the literature, actually the literature would suggest otherwise. So this is data from Dr. Ahushi, and I'm going to show several of his studies throughout the talk. And I don't want you to worry about blue versus red, but just take a look at the data points. And if you were to consider low cardiac index as a value before 2.5, you can see that actually all points are above that. And when we look at the patients that did well, actually their average cardiac index was 2.6, so within the normal range. So I would argue that in 2024, Fontan is no longer a low flow state. And I think it's important for us to remember that a lot of the principles, the dogmas in Fontan physiology, actually come from the AP Fontan era. And the procedure has evolved tremendously, and the patients that we see in clinical practice will typically either have a lateral tunnel or an extracardiac conduit. So we have to be very careful to apply these dogmas from the past in the patients that we're seeing in today's era. But that creates a challenge, right? So what is normal Fontan physiology? Because by definition, everything is abnormal as we compare this to biventricular circulation. So the idea here is what is mathematically normal? What is expected in a patient with Fontan physiology? And this is critical as we see these patients in clinical practice and try to understand their lab results. And Dr. Ahushi has proposed some values for optimal Fontan hemodynamics. So a CVP of 10, a ventricular filling pressure of about 7, and an arterial saturation of 94%. But you can argue these are really optimal, right? Well, what about just simply normal? So what can we use as cutoffs to define normal or abnormal as we're going through their cardiac catheterization data? And there are some efforts to do that. So this is a consensus statement that was published 3 years ago. And you can see they proposed a ventricular end diastolic pressure or a wedge pressure of 12 as abnormal. Excuse me. And I think we do have data to back that up. When we looked at our own experience, a wedge greater than 12 was indeed associated with worse survival in adults post-Fontan palliation. Now, that document did not propose a cutoff for abnormal Fontan pressures. And I think several centers, including our own, have actually used data from Dr. Ahushi, who showed that a Fontan pressure of 14 or greater was associated with high mortality. So we use these results as we try to define what elevated Fontan pressure is. So with those in mind, I think it would be quite reasonable to propose these values for the definition of normal Fontan hemodynamics. So I wanted to remember a wedge of 12 and a Fontan pressure of 14 as we try to categorize normal versus abnormal. Now, with those cutoffs in mind, let's go back to our patient here. And when we look at his numbers, the PA pressure and the wedge were actually pretty normal. And if you look at the cardiac index and the O2 saturation, those are only mild and perhaps moderately abnormal if you look at the O2 saturation. So the question is, can we justify his clinical picture? He's admitted to the hospital with unequivocal Fontan failure. Can we justify that with the numbers that we have in front of us? And this is one of the big challenges in Fontan practice, that we have this big discrepancy between the clinical picture and what the patients are reporting to us and what we obtain in the cardiac catheterization laboratory. And this can be incredibly frustrating to patients and providers alike. So the question is, what can we do to reconcile the two? What do we do now in the cardiac catheterization laboratory to bring the clinical picture and the numbers together? And this is what we do here at Mayo Clinic. We exercise them. And here you can see a picture of our own laboratory. You can see the VO2 machine on the right, but I would like you to focus on what's on the cath table. And here you can see this is a supine bicycle. So we make them do supine cycling during their cardiac catheterization. And this is what we did with this patient. So you can see with that, his complete normal resting hemodynamics became markedly abnormal, with his wedge going up to 32 and his SVC pressure going up to 33. But the question is, this marked rise in wedge pressure, is this what we would expect in our Fontan patients as they exercise? And we try to answer that question with this paper that was published now 2 years ago. And we compared Fontan patients with HFpEF and controls. And this is what we saw. As we compared Fontans and controls, their wedge was pretty similar at rest and during feed up, but the Fontan patients had much higher values at peak exercise. And as we index the changes in wedge by the changes in flow, again, this is a metric of compliance of the system, you can see that the slope was much steeper in the Fontan group. And as we compared slopes, they were quite similar, or actually, you can argue that the Fontan slope was actually even steeper in patients with HFpEF. So personally, I really believe that Fontan palliation invariably results in ventricular noncompliance, and this becomes a progressive issue as these patients age. Now, but you can argue that exercise physiology is much more than just feeling pressures, right? Because we know that one of the goals of exercise physiology is to augment cardiac output to meet the body's demand as we exercise. And how do we do that? We do that by doubling the heart rate and increasing the stroke volume by 30 to 40%. But I wanted to look at these two curves as we compare that to cardiac output to actually remember that their contribution is different, with cardiac output actually being supported by heart rate increase much more than it is by augmentation in stroke volume. So as we keep this in mind, how do we translate these principles to Fontan physiology? And this is what we try to answer in this different study that was actually published earlier this year. And in this study, we actually divided the patients a little bit differently. So we actually categorized patients, the Fontan patients, into abnormal versus normal Fontan hemodynamics. And this was a combination of resting and exercise data. And then we compared them to controls, patients with non-cardiac dyspnea. And the results were actually quite fascinating. Now, if you look at stroke volume index, there was no difference between Fontan patients with abnormal versus normal hemodynamics. And in fact, there was no difference when we compared those two controls. But look at heart rate. So the patients with normal Fontan hemodynamics had no difference compared to the control group, but patients with abnormal Fontan hemodynamics were markedly chronotropic incompetent. So I think this is something to remember, that chronotropic incompetence and Fontan failure often go hand in hand. And it's important that we remember this concept when we analyze CPAT data, and we'll come back to that at the end of the talk. Now, what about feeling pressures? Now, it's no surprise that those with abnormal Fontan hemodynamics had much higher PA and wedge pressures during exercise. But instead, let's focus on the normal Fontan patients versus those with non-cardiac dyspnea controls. And you can see the PA pressure was slightly lower in the Fontan group, but there wasn't much difference in wedge. So the differences between groups were actually quite underwhelming with regards to those two variables. So what is the big difference then between the good Fontans and the controls? And as obvious, as simplistic as it sounds, the striking difference really had to do with systemic venous pressure. And you can see here that the systemic venous pressure in the good Fontan group was much higher than in controls. And I think this rise in systemic venous pressure, coupled with some degree of systemic desaturation that is universal in those individuals, just makes exercise very hard. So in other words, the skeletal muscles cannot cope with this combination of very high systemic venous pressure and reduced delivery of oxygen. This is really the etiology of Fontan exercise limitation, even in those patients that are doing well. Now, this is the exercise data. So what did we learn in that study with regards to the resting data? And moreover, how can we compare those to Dr. Ohushi's optimal values? And the results were even more fascinating. So as we compared Dr. Ohushi's proposed values to our Fontan patients that were doing well, either based on hemodynamics or just clinically, you can see that the numbers were strikingly similar. So CVP of 10, ventricular filling pressures of 6 or 7, low normal cardiac index, and an arterial saturation of 94%. And I think as we look at these numbers, we have to remember that optimal Fontan numbers are probably much lower than what we think and much lower than what we typically see in clinical practice. Now, this is interesting. You can argue that this is important academic work, but what is the clinical significance of this going through this effort of exercising them in the cath lab? And I'll tell you, this is actually clinically important. This is the initial paper by Alexander that actually showed that the exercise data correlated better with end organ dysfunction. And in a subsequent study, we showed that it actually correlates better with clinical outcomes. So this is not only diagnostically important, it actually provides incremental prognostic information. But you can say, well, this is really complicated. There's no way I'm going to be able to exercise patients in my cath lab. So is there anything else we can do? And importantly, is there anything else we can do non-invasively even before we bring them to the cath lab? And I'll tell you, there are actually several options. Now, and I want to start with measuring the peripheral venous pressure, and this followed the work by Jamil Abu Hassan at UCLA, and I think this was a game changer in the way we actually care for Fontan patients, inpatient and outpatient wise. Following their work, we actually looked at our own data, and this is what we saw, that actually the peripheral venous pressure really reflects central venous pressure, so SVC pressures, very well. And this is the case at rest and during exercise. And not only that, actually the peripheral venous pressure during exercise was proportional to wedge pressure. So even by simply measuring the peripheral venous pressure through a small IV, you can get insight regarding the performance of ventricular diastolic function. So remember that in your practice, that peripheral venous pressure is actually your friend, since it equals Fontan pressures even during exercise. So take advantage of that as you see these patients in the outpatient setting. Now, but the question was, can we go one step further? Can we refine that even more? And we did that, and we did by actually combining the peripheral venous pressure and NT-proBNP data, so cardiac biomarkers. And during this study, we actually looked at peripheral venous pressure being normal or abnormal, excuse me, using 15 as the cutoff, and same thing with BNP. And then we phenotype patients having normal PVP and NT-proBNP, abnormal PVP and abnormal BNP, or just having one abnormal value. And as we did that, and as we moved from normal to abnormal, you can see that there was a gradual increase in resting Fontan and wedge pressures. And the same was true for exercise values. As we went from normal to abnormal, there was a gradual increase in exercise hemodynamics. So that told us that we could actually use those two as a surrogate for their hemodynamics. And not only that, this was actually quite helpful as we try to decide who goes to the cath lab. Because look at the patients with complete normal values. You can see that all but one patient had abnormal exercise hemodynamics. So you can argue that the yield of exercise cardiac catheterization in those will be low. Now, similarly, if patients have both abnormal PVP and NT-proBNP, abnormal exercise Fontan or wedge were essentially universal. So you can actually tell the patient that their exercise limitation is indeed cardiac in nature. And I think the patients with just one abnormal value, those are the ones that would benefit the most from a detailed invasive cardiac catheterization hemodynamic assessment. And finally, what about treadmill? Is that valuable or not? And then we do this all the time in patients with Fontan. So can we actually use that to have a surrogate for invasive hemodynamics? And we do this all the time with patients with biventricular circulation. And I'll tell you that we can. And this is a paper that was also published this year. And you can see here that in our experience, peak heart rate, again, going back to the concept for chronotropic competence, so peak heart rate and peak VO2 were the best predictors of abnormal exercise hemodynamics post-Fontan. And as we try to dichotomize or just get a cutoff for abnormal, as we try to predict invasive hemodynamics, a peak predictive VO2 less than 48 was the optimal value in terms of detecting abnormal exercise Fontan hemodynamics. So I'll finish by saying that CPAT and NT-proBNP are actually quite helpful, and they do provide clues for abnormal hemodynamics, and they're incredibly helpful trying to define and determine who needs to come to the cath lab for a detailed invasive hemodynamic assessment. And with that, I'll end. Thank you very much for the opportunity to speak, and I'll be happy to participate in the question and answer session. Thank you very much.